So now we're going to be continuing with the theme of transplantation, but from a different perspective. The next talk is entitled New Paradigms for Transplant Surgery in PSC, MELD and Living Donor Considerations. And it gives me great pleasure to introduce Dr. David Mulligan, the Professor in Chief of Transplantation and Immunology at Yale University and Yale New Haven Hospital.
Thank you, David, and it's really an honor to be here to speak with you. It's empowering to me to see so many caring and compassionate patients and providers here to try and come up with better ways for us to manage this very debilitating disease. And I've got two really important things to talk to you about in a very short period of time. And one has to do with the problem that we have in this country right now dealing with our scarce resource of livers and this MELD system that you heard about, and some of the limitations that we have with that, as well as talk about a little more in depth about living donor liver transplantation. Well, as you are very familiar, and I don't need to remind you, and we've been reviewing that throughout this talk, PSC is a very important disease that hopefully can be managed before you would ever need to see me. But when the disease continues to progress, we see this continued progression of disease, which is very debilitating and unfortunately not very well captured by our MELD scoring system. And this is a big problem. It affects predominantly males. Most of it is associated with inflammatory bowel disease, as you've heard. And even after transplant, the myths about the immunosuppression, taking care of the IBD after transplant, is not always true. It's been my experience at the Mayo Clinic when I was there and here at Yale that we see about a 50-50 chance whether a patient's going to get worsening of their inflammatory bowel disease after transplant or whether they're going to have improvement of their IBD control. So there's no way for us to really tell you. And I think that, as we heard on the last presentation, it's so important to really stay in close touch with the management and with your GI doctor to manage that IBD, because getting a transplant doesn't put an end to the IBD when you have PSC. And having family members with PSC can certainly increase that risk. You know the symptoms of the fatigue, the itching, loss of appetite, weight loss, and I bring this up because these symptoms are not symptoms that we can get some type of priority for allocation for. And that's a real problem because it's debilitating, but it's not something that we have the opportunity to try to give some type of priority because you're still alive and you're not literally months or weeks or days from death as we're trying to distribute this really scarce resource. And you've generally got health care that's managing you well, but not in some areas of the country where there's very little access to health care for patients with liver disease, which David's written a lot about and tries to make us aware of. So this is a disease that we don't really have a good way to allocate organs for when it continues to progress and get worse. So a lot of people suffer. There's a lot of infection risks, vitamin deficiencies, certainly extensive scarring causes of cirrhosis, liver failure, and this ever challenging risk of cholangiocarcinoma, the bile duct cancer that is seen more commonly in people with PSC, very difficult to diagnose, and only a very small subset of these patients do well with liver transplant. As we've seen in the Mayo Clinic experience, you can have phenomenal outcomes, 80% 5-year survivals, if your disease is confined within very limited criteria, which about 19% of the patients that present with cholangiocarcinoma actually have. So that's a big problem. The vast majority of patients, over 80%, when they develop cholangiocarcinoma, already are beyond the criteria for a liver transplant to have a meaningful long-term outcome. And so this is a big issue. So the diagnosis, you know how it's made. You've heard about this, and the risks are certainly very significant. Not only do you have to deal with cholangiocarcinoma, but you also have to deal with hepatocellular carcinoma. And this can be seen in conjunction with the colorectal carcinoma that you can get from the inflammatory bowel disease. So now you have this triple threat of malignancies, not only on top of debilitating diseases in 2 organ systems. So that's very difficult. The idea to treat this is to target the symptoms, to decrease the inflammation, to correct some of the deficiencies that you have. And liver transplantation, as you've been hearing in the last talk, is certainly an ideal option when it's available for patients whose disease is continuing to progress. And as we look at the issues in the United States, and what I want to focus on for the next couple of minutes is, what does this look like, and why are we talking about this? Why did they ask me to be here to talk to you about the issues that we have? Unfortunately, there's a profound scarcity of organ donation. And there's not enough donors, as you heard, not only because improvements in the management of trauma and improvements in the management of how we have laws to have speed limit controls and seat belts and those kind of things. Changes in how we manage brain injuries have been profound. And so it's shifted what I first started to train with as a transplant fellow in Dallas to what we have now, which is a donor frequently 20 or 30 years older, usually dying of a stroke with other comorbidities. And it's a whole different quality of a liver that we have to deal with right now. And it's a problem. Sadly, the heroin epidemic that we're seeing in this country today is generating a lot of very young donors. And that gives me a lot of pain to see so many young people that are dying with needles in their arm from heroin overdose. And that has to be stopped. There are over 120,000 people on the transplant waiting list in the United States right now, and as of June 17th, 14,697 are on the list for a liver. That's candidates on the list for a liver. And 6,622 are receiving a deceased donor in 2015, with 359, which is actually up by about 100 have received living donor grafts. But that's only half of what we were doing several years ago before we had a tragic donor death, which caused a big halt on the progression of living donor liver transplant in this country that has been growing all over the world. And that's something that I think you can do something about. The sad truth is that if you look at the mortality on the wait list, there are more than 2,800 people dying without life-saving organs. That's about 20 people who receive transplants a day, with 8 people dying a day in this country. And that's sad. So what do we do, and how do we work on a national level with many physicians and surgeons? David Goldberg here at the table has worked by my side on this for many years to try and allocate and distribute, to create policies, to try to distribute this scarce resource and to create national policies to make a difference. Well, we try to do something that's very efficient and make very effective, efficient organ offers when there is a donor. Oftentimes it's in the middle of the night, holidays, weekends. As Dr. Rodriguez, I'm sure, told you yesterday, we have most of our activity, probably 80% of it occurs on nights, weekends, holidays, not during the regular Monday through Friday workday. So there's a lot of things that have to happen. It has to happen very quickly. The organ procurement organizations have to be able to get in touch with us very quickly and very efficiently to get the organs to where they belong. We have to be able to have electronic offers with a lot of data available at the transplant centers so they can make sure these are correct. And then we have to have a way to distribute or get these organs to where they need to be. And that's a big, important piece. We have to do this in a way that we can maximize the utility and the benefit for all those organs and where they need to go, and avoid putting organs in lost cause recipients, which is a really difficult issue for us to face as we've seen higher and higher MELD scores being what draws and competes for livers in this country. And we also have to be fair and just so there's equity for access for livers regardless of where people live. And this is not easy, as David can tell you. This is very difficult, and we all have to work really hard to try to make this happen. So what's been happening, and just so you have a snapshot of what I'm talking about, back in February of 2002, taking this MELD score, which originally was the Mayo End-Stage Liver Disease Score, created by Pat Kamath and Ray Kim at Mayo Clinic in Rochester, to try and grade the mortality of a patient who had portal hypertension and see how long they would live based on a bunch of different factors of their disease, their age, their sex, what type of disease they had, when they would get a TIPS shunt. That's where it came from. And it was that team plus Russ Wiesner that applied it to transplant. They made it simpler, they showed that it's reproducible, and we've used that, and it's been the most reproducible, effective score to try and tell us how sick a patient is and what their survival is in 90 days on the transplant wait list that we've ever had. But, as you all sitting in this room can attest, it's not perfect. And there are many people who have symptoms and other morbidities of their disease that aren't captured by the MELD score. But in 2002, we introduced this. It was a way to get organs to the sickest patients first and take away the waitlist priority. In '99, it's not 1999, but following the 2002 allocation, we moved into this regional sharing agreement. That should be 2009. And regional sharing meant that we were sharing across the region for status 1s initially. Now we have regional sharing for MELD of 35 and national sharing for MELD of 15. We've also recently introduced some policy to try and prevent some of the exception scores for things like HCC, which have occupied about 45% of the organs that we're transplanting in this country now. We've managed to control that because that's been driving a creep, causing more and more patients who have these hepatocellular carcinomas to get priority points probably over and above what they need, more than their death rate occurs, more than their tumor progression occurs, and we don't feel like it's a fair use of the organs, these life-saving gifts. So we've tried to decrease that priority to some degree so that we can put them in the right place. So we've capped the HCC maximum MELD score at 34, and we've also built in a 6-month delay plan so that when a patient gets diagnosed, we can follow the tumor biology. And we've got good scientific studies to show that works. And we can follow that tumor biology to make sure that that patient has an aggressive tumor that needs a transplant at the right time, but they don't have tumor biology that shows that the tumor is too aggressive and the transplant is not really in their best interest. And we put that organ into somebody who's not going to have a good outcome. And then we also added sodium to the MELD score, the creatinine, the bilirubin, and the INR. We've added sodium factor because in middle range MELD scores, having really low sodium does affect their mortality. And that's an important factor to try and add in. So we've done that. And what have we seen with this broader sharing and trying to make some of these adjustments so far? Well, we've seen that we can effectively help the patients who are the sickest with these MELDs of 35 and up, 35 and above 40. We've been able to reduce their death rate on the wait list. We've been getting them organs more readily, which is what the policy indicated. There's a lot of questions about, are we transplanting the right people by focusing so much effort on these very sick patients and not transplanting people who may be a little more robust and stronger and do better long term with a healthy liver, getting it when their MELD scores are lower, and we're trying to resolve that and make the right decisions to do that. But right now, we've been delivering organs to sicker patients and getting them organs faster than we had before with the effort that they're not staying so sick for too long, and we've been able to do that and make an impact. And their long-term survival has been the same, and it's been the same at least out 2 years as the survival across all of our patients' paradigm. But what we've seen is we continue to have this disparity of access to transplant. If you look at what your MELD score is at the time you're offered a liver. That's the MELD at transplant as a variable to try to determine what we can measure from one area to the other. We've seen that access to MELD at transplant is still quite different, and that's a big problem. And we've seen that it's been more costly, and there's been a lot more transportation demands. So there's more cost up front to do that. And those are important factors. So broader sharing comes at a price, and it comes at a price up front for transplant centers and for payers, insurance companies, Medicare and Medicaid. So this is important, and we have to do something about it. We have to be prepared to fix this. But why is this such an important thing? Because as you see, patients who have the highest MELD have the highest risk of death on the wait list. And this is a big deal. Look at how it doubles from MELD less than 15 of about 8% to twice that much for the median MELD of patients between 15 and 34, to then twice that again when you get into this highest risk group. So right now, we've strategized to really deliver to this highest risk group, and this is a dilemma we're seeing more and more and more of. And I show this chart because this is our Share 35 data, which is recent data that we've had, and it shows a 2-year period before and a 2-year period after Share 35, which gives you a pretty good capture of MELD since 2011 and what we've seen. And the reason I show you this is divided by the 11 UNOS regions that we currently have. And instead of seeing these green and gold bars being fairly straight across the back here, we're seeing incredible variation depending on where you live as to what the MELD at transplant is. And this is a problem. And that is why we need to look at living donation. So there is an opportunity for living donation, and this does make a difference, as you've heard, and it's a profound one. We have to be very careful as we look at potential donors. Usually family members or close friends, and even anonymous donors are now very successful living liver donors. They go through incredible, very careful reviews. We look at them based on their ability to donate, the size of the recipient, the size of the donor. We evaluate their anatomy. We try to look very carefully using very fancy 3D imaging where we can divide the liver virtually and measure exactly how big the right lobe, the left lobe are, where all the blood vessels are, so that when we do the surgery, we can in real time see what this looks like. And we can use these tools to try and make very careful, very calculated, very exact abilities for us to be able to make the calculations to know what's safe. And that's very critical, is knowing before we do surgery what's safe for a donor. And we take the risks for donation very seriously. There's a 0.2% chance that a living liver donor may not survive. But we call a lot of attention to that, and we take it very seriously, but that's less than the risk of riding on a motorcycle or working at several jobs like police officers and firemen do every day. And we take those risks without even thinking about it. If it was your kid, if it was your sibling, if it was your close friend, would you be willing to do that for them? And that's what this is all about. And so our job as transplant centers is to do this careful evaluation, find donors who can be good living liver donors and make a difference. I'm going to include a little bit of data just to show you how much study has been done worldwide and nationally about living donation, and I hope that you'll have access to some of this information afterwards, and we can have this available to you so that you can read it at your leisure. But it just goes into details and summaries of the meeting at the International Liver Transplant Association, showing the outcomes between right lobe and left lobe living donors, about 23 donor deaths out of 11,500 living donor liver transplants around the world. It's very serious, and we continue to study. The A2All group, of which David's program is a member, is a very important group that's been following 790 patients who received living donor liver transplants, and they've been following these patients out beyond 10 years now. And what I want to show you that is really important about that is that they've learned a few caveats. One is that centers that have experience, as we heard before, of at least about 15 to 20 livers or more can have a significantly better survival than their patients at centers that don't. So it's important to be an experienced center where the whole team is capable of working on living donation. And it's also important to look at beyond 2 years as we get to 3 years, 5 years, and 10 years out from living donor liver transplant. There's a statistically significantly better outcome for patients having living donors than for patients undergoing deceased donors. Even for the patients that may not ever get to a deceased donor transplant, it's better. And it's better for a lot of reasons. The right lobe is an operation that's similar to a total whole organ transplantation, and we do that, and this technically shows how we hook in a right lobe transplant. And this is a liver that's being split. The left lobe transplant is trickier. We try to look at left lobes, and we try to do that because we try to look at ways that we can potentially take less liver mass from the donor in a way to try and reduce some risk to the donor. In fact, depending on the studies that you look at in a well-experienced center, whether you use the right lobe or the left lobe, the risk is about the same. But the key is, can we make more smaller livers work in sicker patients by modulating some of the things with pharmacology and by some other tricks to reduce splenic flow and things like that to make the left lobes more successful. I've had experience at the Mayo Clinic in Arizona where we've done about 150 living donor liver transplants. We found the same thing out to 5 years, statistically significantly better for our living donor liver transplants than for our deceased donors, all by the same surgical team. Here at Yale, Dr. Shukru Emery and myself are 2 experienced living donor liver surgeons who have done over 200 of these now each. So we have a robust experience here to perform these transplants, and the outcomes here have been phenomenal. Over 75 patients since Dr. Emery got here in 2008, and we continue to grow our experience. About a third left lobes and a third right lobes, and we have a very extensive pediatric transplant. About a total of 12 of these patients are for PSC, 2 pediatric PSC patients and 10 adult PSC patients. So again, a lot of experience with doing these partial liver transplants with outstanding outcomes, 90.1% survival in our deceased donor transplants, and 96.5% for the living donor transplants that we see here at the 5-year mark. What I'd like to show you is a couple of pictures on a story, and I'd like to close with this story because it's really important. And this couple is sitting right here on the second table in front of me. And this is a story of a young man who's 33 years old, and he had been waiting on the transplant list for 5 years with PSC and going through all the things that many of you are familiar with: progressive itching, fatigue, profound muscle wasting, refractory ascites. He would get umbilical hernias that would leak and constantly create admissions to the hospital, very low sodiums. He was really in trouble. He lost so much muscle mass that his serum creatinine was so low because he didn't have enough creatine from the muscle to elevate that creatinine to make a competitive meld. So his highest creatinine his highest meld could be in the mid to upper 20s. And that was when he was having an infection, and then it would fall down to the mid and low 20s. So it was desperate. My partner and I saw him many times when he was in the hospital. We discussed options, and he was trying for living donation, but he was getting so sick. My partner even felt that he was too sick for a partial graft. He had gotten too far, as you had mentioned before, to have a partial graft. And so as we had a debate, I was convinced that his wife, Jen, was going to be suitable, and that with the mass that she had from her right lobe, we could get him a life-saving transplant. And we were literally at that point making that decision of what we could do. And here he was with his wife when he was at his sick point in the hospital and waiting. Here he is now. This is the difference that living donor made. And here they are. So this is what living donor liver transplant is all about. This is what you have the power to make a difference about. Most people tell me, most people tell Jen, who's been one of the biggest advocates for this, since she did this, she goes all over telling everybody about this. But most people say, I didn't know I could do that. And I can imagine all of you hear the same thing. I didn't know I could donate a part of my liver. I didn't know that that was safe. I didn't know that I thought I had to be a blood relative, or I didn't know that this could be possible. Well, you can. And there are people that will do this. Yesterday, I did a transplant on someone who was trying to fill out the GoFundMe page because they were on dialysis for 7 years, and they didn't have any suitable living donors. Everyone was medically inappropriate. And that somebody signed up on the GoFundMe page and said, I don't have any money, but I'll give you a kidney. And he came out from Baltimore to New Haven, and he gave a kidney. And people will do that. And people will do amazing things if you give them a chance. So become a champion. Talk about organ donation. Talk about living donation. It makes a huge difference. And if there is any group of liver disease patients that need to focus on the power of living liver donation, it's PSC, because that can make a huge difference. Thank you very much.